Good afternoon, everyone. This is the final session of the day. We've had a lot of people who had to leave us early because their flights were in the early afternoon. So what I decided is, instead of covering the topics that we had mentioned a couple of topics which are interesting. We wanted to do the white matter of the brain, then we wanted to do the venous system of the brain. Those are again things which are not discussed in routine meetings, but we had wanted to discuss it here, but I have had requests from a lot of people not to do it this time, maybe do it the next time so that they can attend that as well. So what I decided now is we will finish the session with a video demonstration of an AVM embolization of the corpus callosum. Now, corpus callosal AVMs are rare. They are less than 1% of all brain AVMs, and they are relatively difficult to treat as well. If you look at the corpus callosum, I think I'll draw a couple of images of the corpus callosum to try and illustrate what exactly I'm talking about. So what I'll try to do is, I'll just try to converge the phylogeny of the corpus callosum, the development of the corpus callosum in 5 minutes, and then try and show you how exactly the blood supply to the corpus callosum comes, and then we will look at the embolization. So basically, what we should understand is that the corpus callosum is basically the largest association fiber system in the brain. Anatomically, the corpus callosum has a rostrum or the beak, then it has the body, and finally it has its splenium. If you look at the corpus callosum from above, you will find that you have the corpus callosal fibers in the center, which are going from the right hemisphere to the left hemisphere, or left to right, or whatever you want to call it. The anteriormost fibers of the corpus callosum that are going into the frontal lobe are basically the fibers of the forceps minor. Subsequently, you have the fibers which are going posteriorly, and they are curving around the posterior horn of the lateral ventricle, and they are going to the occipital cortex. These are the fibers of the forceps major. And then you have some fibers in the center, which is the majority of fiber systems in the center, which are the fiber systems of the tapetum. So these are the three basic fiber systems of the corpus callosum. But what we have to understand, what we have to realize is, if we look at the development of the corpus callosum, if we look at the phylogeny of the corpus callosum, what basically has happened is, you have had a situation at the 20 mm stage of the embryo in which the entire hemisphere of the brain looks like this. We are looking at both the hemispheres. The hemispheres look very smooth. The brain is completely lissencephalic. It is completely smooth at this stage. There is no gyration. The first indentations which are going to form the sulci appear somewhere here. They appear somewhere here. And then they appear somewhere here. So this is called as the fissura marginalis. This is called as the fissura rhinalis. And this is called as the fissura hippocampi. So ultimately, from the 20-week stage, when this embryo develops, this is basically going to form the superior limb and the inferior limb of the circular sulcus. This is going to form the cingulate sulcus, and this is going to form the collateral sulcus. So what we have to understand and what we have to learn is that in the brain, these three sulci are basically the oldest sulci. Around it, you have the frontal operculum. Below that, you have the temporal operculum. Inside it, you have the insular cortex. Around this, you have the cingulate gyrus. And around this, you have the floor of the inferior horn of the lateral ventricle and the hippocampal, parahippocampal gyrus systems. So the first three sulci to appear in the brain were these. Therefore, the first set of gyral systems to develop in the brain are also these three. The first set of gyral systems, that is a conglomeration of gray matter, that is neuron cell bodies, happened around the area of the cingulate sulcus, in the cingulate gyrus. It happened in the hippocampus. And then it happened around the insula and around the frontal operculum as well as the temporal operculum. In the next stage, from each of these gray matter condensations, you are going to have their axons which are coming out. So the first set of axons that started coming out came out at the superior limb of the circular sulcus of insula, at the inferior limb of the circular sulcus of insula, at the collateral sulcus in the hippocampus, and in the cingulate sulcus in the archipallium. In the next stage, this was an axial orientation that we are trying to see. Now we will just go to a sagittal orientation. In the sagittal orientation, what we will see is that these four fiber systems which were developing in the brain ultimately give rise, for example, this one gives rise to the cingulate bundle. This one gives rise to the superior longitudinal fasciculus. This one gives rise to the inferior occipitofrontal fasciculus. And this one gives rise to the inferior longitudinal fasciculus. So remember that in phylogeny, the association fiber systems, the longitudinal fiber systems which go from anterior to posterior, are phylogenetically much older than the projection fiber system, because till now we don't have a projection fiber system. In the next stage, when we come back to the coronal orientation, to the axial orientation, we have these bundles, we have these bundles, and we have these bundles. Two bundles are medially located, two bundles are laterally located. If you were to join these, this is what forms Now we are in the coronal orientation. That is the midline, that is the right lobe, that is the left lobe, that is the corpus callosum, that is the ventricular wall, that is the ventricular wall. And basically, we now have four fiber systems, one fiber system here, one fiber system here, one fiber system here, and one fiber system here. We have these four fiber systems which are going from anterior to posterior, and they are giving us an imaginary circle which is basically the phylogenetic circle. Whatever is inside this circle or whatever is at the edges of this circle is old brain, and whatever is outside the circle is new brain. Now, in phylogeny, the projection fiber system initially was originating out of the basal ganglia. If you look at amphibians, if you look at fishes, their projection fiber system, the corticospinal system, goes from the basal ganglia. Because for them, for survival, for reproduction, for finding food, everything happens at a reflex level, at the level of ganglionic motor reflexes. It is only when you come to late amphibians or reptilian phase is when the projection fiber system also starts getting some contribution from the cortex. That means from pure reflex activity, now you can modulate that activity. So basically, the projection fiber systems are going to originate and they are going to interact with the fiber system that is originally originating from the basal ganglia. So now you have a situation in which you have a concentric anteroposterior fiber system which is being intersected by fibers which are coming from above. That is the corticospinal system. Now this intersection happens at the ventricular edge. So at the ventricular edge, you have a situation in which you have the transversely going fibers of the corpus callosum, and then these are intersected by the vertically going fibers of the projection fiber system. So why I'm telling you all this is, at the ventricular edge, you have a situation where the fiber tracts crisscross each other. The fiber tracts, this one is going down, this one is going transversely, they crisscross. So this area of the distalmost part of the corpus callosum, the lateralmost part of the corpus callosum, where it interacts with the descending fiber system, is an anatomical boundary for the spread of diseases like gliomas. You will find that whenever you have a glioma in the telencephalon, this glioma usually will not cross this boundary and go into the deeper structures. But during surgery or during biopsy, if you open this boundary, that glioma is going to go down. Now coming back to the topic of AVMs, what you should also realize is that the corpus callosum is located inside the phylogenetic circle. The corpus callosum just above it has a band of gray matter called as the inducium graecium. And the anterior cerebral artery is just looping over this. So if I were to draw the corpus callosum here, you will realize that the closest artery to this area is the anterior cerebral artery and its branches. So obviously, the corpus callosum is going to derive most of its supply from the anterior cerebral artery, and the angioarchitecture is going to be different in the anterior part of the corpus callosum, the mid part of the corpus callosum, and the posterior part of the corpus callosum. We have discussed in the previous session that arteries follow peripheral nerves. When there are no peripheral nerves here, you have fibers of the corpus callosum acting like peripheral nerves. So, in the anterior-most part, the arteries that are supplying the corpus callosal AVMs or the corpus callosum themselves will be longitudinally arranged like this, along the fibers of the forceps minor. Posteriorly, the blood supply will be arranged like this, from the pericallosal artery, the anterior pericallosal artery, or the posterior pericallosal artery in this fashion. And when you come to the central part of the corpus callosum, where the AVMs are most common, you will find that these are supplied by the long callosal arteries, and the short callosal arteries. Long callosal arteries are those arteries which will go along the length of the corpus callosum. Short callosal arteries are the arteries which will behave like the sulcocommissural system in the spinal cord. They will be very short, they will be vertical, and they will be almost impossible to see. But you have to anticipate that these are the vessels that you are going to encounter when dealing with an AVM. So remember, corpus callosum basically phylogenetically is an offshoot of the fibers of the fiber systems from these 4 longitudinal fiber systems. You have offshoots that ultimately form the corpus callosum. The corpus callosum lies inside the phylogenetic boundary. When the corpus callosum lies inside the phylogenetic boundary, obviously it belongs to the old brain system, which is at least 200-250 million years older when compared to the rest of the circulation. And subsequently, the blood supply to the corpus callosum is going to be different in the anterior part of the corpus callosum, in the posterior part of the corpus callosum, and in the mid part of the corpus callosum. Corpus callosal AVMs are rare. They are 2 to 3% of all brain AVMs. And out of these, maybe 90% are in the mid part of the corpus callosum. Anterior and posterior are extremely rare. So now I will just show you a case of a mid-callosal AVM and how exactly we treated this patient. So this is an entire case that has been recorded in live conditions. This was a patient, this is a young patient around 16 years old with an AVM of the corpus callosum, of the mid part of the corpus callosum. When you look at this angiogram, when you look at the AP and the lateral projections, you basically, what you see are a big clump of vessels. You see that the pericallosal artery is the one which is probably supplying it. You have a venous drainage which is going superiorly, and you have a venous drainage which is going posteriorly. But as of now, in this image, you do not see any targets that you can catheterize and that you can treat. So basically, we went ahead and we did a rotational 3D. Rotational 3D also showed us the AVM in toto, but it was not able to tell us where exactly the blood supply is coming from. It seemed as if the entire pericallosal artery is opening into the AVM, and then distally it is continuing in the posterior margin of the AVM as the distal pericallosal artery. As is the convention, this is what is called as a cone beam CT, a cone beam CT reconstruction of the entire AVM, where again, we are not able to see anything great on this MIP projection, but then we start taking thin sections through the AVM. When we take these thin sections through the AVM, these are the deep medullary veins, and when we come to the AVM proper, we realize that we have quite a few short callosal arteries which are originating from the pericallosal, and then subsequently we have a couple of long callosal arteries, one long callosal artery there and one long callosal artery there. So we know that now, for treating this AVM, we have at least 4 different targets, but the aim is to enter into the pericallosal system. From the pericallosal system, you have to go distally, you have to go into the long callosal arteries, into the short callosal arteries, and then inject from there. Whenever we do any AVM, this is what I'm thinking. In my mind, this AVM has got at least 2 compartments, one anterior and one posterior. There are definitely intercompartmental connections. You have 2 sets of draining veins, one draining vein which is going superiorly, that is an ascending internal frontal cortical vein, and one vein which was going posteriorly into the deep venous system. So based on this information, we go ahead. The most important part of this entire process is to achieve a wedged position in one of the short callosal arteries or long callosal arteries. So you can see here that we are in a very good wedge position. That is what we would like to achieve, and this is just to show you how we went about doing that. We use typically just a 5 French diagnostic catheter as a guide in all our cases. Subsequently, that is a microcatheter, that is a marathon. We have to go into this area. That is where we are entering into the pericallosal system. You go into the pericallosal system, and then you go distally. And once you are in that position, then you start looking at how exactly you are going to enter the short callosal arteries. The previous wire was not behaving well, so we just reshaped the wire. Now we have put the wire in again. Once we take the catheter higher up, do one injection, see where we are. So you will see probably, you can see that we are still in the pericallosal system because you are opacifying the distal part of the pericallosal artery. You are opacifying the posterior internal frontal artery. So this is not a good situation for you to be injecting from. So you have to use this image as a roadmap. And then you have to super selectively, you can see that this is the pericallosal artery, and what is going above is the long callosal artery. So you have to enter into that vessel and then come down to the AVM. Mind you, these are around 250, 300 micron vessels, very, very small. So you have to be very gentle, you have to be very careful, and slowly by catheterization techniques and doing whatever we were discussing yesterday, loading the microcatheter. You can see that the microcatheter has been loaded completely, then removing the wire, transmitting the inertia, and subsequently the microcatheter ultimately goes into the AVM. So now I'll just make a long story short. I will just show the position where we were able to reach the target. Yeah, no, this is still not the case. Again, this is also still not the case. We are still opacifying the posterior internal frontal artery. Still not the case. We are able to opacify. We are able to opacify. Yeah. So I'll just go back. Now, this is a situation in which one of the long callosal arteries has been selected, and this is a wedged position. You will see the injection again. When you see the injection again, you will notice that as long as I'm injecting into this area, as long as I'm injecting into that area, the contrast is flowing forwards. Now I'm just bringing that to the center of my frame, and you can even see the contrast stagnation there. You can see that? That is the contrast which is stagnating in the AVM. So this means that you are in a very, very optimal position. You are wedged, and there is no flow that is going. You can see that is the contrast. See that? That is the contrast which is stuck in the AVM. So this is an ideal position for you to take out as much of the AVM as possible. We are ready. We bring this to our center field. We just do a couple of more injections to make sure that by some bad luck, the catheter has not popped out again. The catheter is still there. You are not seeing any opacification of the internal frontal artery, and subsequently you are having opacification of the nidus. The upper part of the vessel is stagnating, but this is washing off because of the intercompartmental connections. You are having one more compartment anteriorly, which is making this contrast get washed off. So that is the live video feed. That is where we are preparing our embolic material. In this situation, this is a wedged position in a very small artery, so we would use a dilute glue. We will go with maybe something like around 25%, 30% glue. And we prepare it according to our chart, which we discussed yesterday. Once the glue is prepared, I think we'll again skip that part as well. Yeah, now we are almost ready for the glue injection. That is the nidus. Everything has been prepared. Now we'll flush out the entire catheter with 5% dextrose. The initial part, we will flush out the contrast material which is stagnating inside the AVM, and then subsequently we'll wash off the entire system with 5% dextrose. Yeah. We do one more check shot, because sometimes, you know, what happens is you have engaged with your catheter. There's a lot of inertia in the catheter. So just when you are about to inject your glue, you'll realize that your catheter has popped out. So always check and cross-check. We also did an injection from the ICA to make sure that all the other vessels were okay. Since we are so deeply wedged into the distal pericallosal artery, you can see that the ACA is not filling from this side, but that is just because there's a catheter inside it, and so much of movement has caused a bit of spasm there. So because of that also the ACA is not filling. That is not for concern, because the moment we remove this catheter from there, this ACA will fill again. So now, I think, yeah, I'm mixing the glue there. That is the glue being mixed. And yeah, that is probably the lipiodol being added. Now I have my glue mixture ready in the syringe. We keep the syringe separately on some cloth or paper or anything which does not have any saline or anything in it. And now we start injecting and we start seeing, we do the flushing now. We flush the entire system. This is just the previous view which is playing again and again on loop. Yeah. Now what we are doing is I'm washing off all the contrast in the system. So I'm injecting 5% dextrose, and with this 5% dextrose, all the contrast that was in the system is getting washed off. So you have to wash off the entire, remember the whole AVM is wedging. That means there is contrast inside the AVM also. So you need to get all that out, wash it 4-5 times. The dead space of this catheter is hardly around 0.25 to 0.3 ml. But still we take 1 ml syringes and we take 5 or 6 shoots. We wash off completely. And then what we do is we wash the hub of the microcatheter also. Because the hub of the microcatheter also sometimes contains some ionic material from where the polymerization can start. And once we are absolutely comfortable with everything, we do the glue injection. Now this is a wedge position. So from a wedge position when we are injecting, you will see that we will be able to make a very, very long injection. So now the glue injection has started, probably. We will see the glue coming out. We should see the glue coming out from there. We're being very slow, very deliberate, very, very gentle. Yeah, that's the glue coming out now. So you had the first couple of droplets of glue flying off. You have to be on your toes, and this is the time when you decrease the speed of your injection. Still you saw that one droplet of glue flew off. Now we are filling the vein. Now we increase the pressure a bit so that we start refluxing anteriorly into the collector vein, and this again now starts going up into the cortical vein. You will see that this was the first compartment being injected. We are still injecting, we are still injecting, we are still injecting, we are still injecting, and then you will start seeing that this area starts filling up from where the ascending cortical vein was filling up. So this was almost a 40-45 second injection of very dilute glue inside the AVM nidus without any reflux. There's absolutely no reflux. You can see that the tip of the microcatheter has left the midline and you are in a short callosal artery, but we have managed to fill off the entire posterior part as well as a part of the anterior compartment of the AVM. Now at the end of this, we do a check shot. We don't do any routine changes in the blood pressure or in the heart rate during these regular embolizations. That is only when we have high flow fistulas that we take care of the flow. We reduce the flow a bit more. What we also do is the moment you remove the microcatheter, you disconnect the hub, you flush the Y connector completely, because sometimes while we're drawing, a couple of droplets of glue might be in the Y connector. So wash it, then again reconnect it, and then we do a check shot. So at the check shot, we expect that the entire posterior part of the AVM would have been embolized, and now we will be left with the anterior compartment. Yeah, that is what has happened. The entire posterior part of the AVM is gone. The anterior part of the AVM is still there. The flow in the AVM has decreased considerably. It has become quite slow. And now, after we finish this, we wanted to do one more injection and finish off the anterior compartment of the AVM as well. You can see now you just have a short callosal artery. You were in the long callosal system previously, now you are going to be in the short callosal system. So this becomes even more difficult. But at this stage, you have to go on because you have already penetrated into both the venous exits. So when you have occluded both the venous exits, this is the time when you cannot stop embolization and you have to go ahead. We are choosing our roadmap mask. In fact, you can already see that the posterior venous drainage is completely gone. The anterior venous drainage, the anterosuperior venous drainage is the one which is still present. So this is the one that has to be knocked out now. Let us accelerate this process a bit more. This was after the second injection. Okay, we probably have the second injection there. This is just before the second injection. And this is after the second injection, yes. So after the second injection of glue from one of the short callosal systems, we can still see that a very tiny part of the AVM is still remaining. The rest of the AVM is gone. The venous drainage on this side is also gone. The venous drainage posteriorly is also gone. So now at this stage, you have an option. You can either stop or you can finish off the case and give a complete embolization at this level also. If you are not comfortable on catheterizing these very tiny vessels, you can stop at this level and send the patient for gamma knife, or bring the patient back after maybe around 2 to 6 weeks and then finish off in the next session. If you are not comfortable, I'm never comfortable leaving an AVM behind. So you have to go ahead, you have to continue the embolization. You have to continue the embolization. Again, you have to do the catheterization. And with the catheterization, with the final glue injection, this is where you reach. So now the entire AVM is gone. The entire AVM has been occluded. You are not seeing the pericallosal artery filling very well. That is partly because of spasm, because I will show you, we have it in the console when we go to the lab. After maybe around 2 to 3 weeks, we had done the angiogram and the pericallosal artery was completely free. We had a doubt that we have occluded the pericallosal artery, but the patient did not have any deficits, and on follow-up angiogram, we saw that the pericallosal was still there. So remember, in the first injection also, when we were trying to do an injection from the internal carotid, we were not able to see the entire ACA. So this is basically because there has been so much of maneuvering inside the vessel that those small vessels have gone into spasm. There might also have been some microthrombi because the microcatheter was there for quite some time. Anyway, this patient was not given any anticoagulation or antiplatelets, and he ultimately made a very, very good recovery. So that should be the final one. What tiny vessels you are seeing here? Again, we don't chase these because these are stagnating. These are the compartments inside the AVM where you have a lattice of glue and you still have some spaces in between those individual lattices. So these will get thrombosed over the next 2 to 3 days, and we don't have to chase those tiny residual filling vessels at all. So this should be the final run. Yeah, this is the final run after embolization. As customary, we do a 3D. In fact, in the 3D, we see all the vessels. You can see that? You can see very faint ACA filling up completely. Yeah, and this is the final. So you see that the ACA is still there. There's no problem. The AVM is completely gone. The ACA is filling up very nicely, and this AVM is cured. After embolization, the typical plan is to bring back the patient after 6 months for a control angio. And if the 6-month angio is also negative, it does not show any growth of the AVM, then we don't do any more DSAs. We follow the patient up for maybe 1 to 2 years with just a MR angio, a contrast-enhanced MR angio. And if that is also clear, then we tell them that they have no reason to come back to us. So I think with this I'll stop, and now we will, in another 15-20 minutes, we'll leave from here. We will go to the lab. Whoever wants to come can come, and we will continue the discussion there. I mean, that will be an impromptu discussion, whatever you want to ask in the lab about the lab, because that is also, as a lot of you pointed out, that is also an important part of the course, because you need to see how exactly the lab functions and how exactly you build up a neurointerventional program. So I will stop here. If there are any questions, if there are any comments, if there are any queries, any things that you did not understand. Vineet.
You said that you have wedged, that's why you are injecting lesser glue. For example, we are not able to reach in a wedged position. Then will you increase your concentration or will you decrease your concentration? What would you do? Because you yesterday said that you will never decrease it less than 20%,
yes,
otherwise it will fly off.
Yes.
So now here you injected 25%. What if you are not able to reach in a wedge position?
Then we'll probably have a more concentrated glue, maybe add 5 to 10% to what we did here. So that there we'll be working in maybe a 30 to 35% combination.
Because you think then that's a high flow system, relatively high flow than it.
Yes, yes,
So
absolutely.
here we are working in a simple conduit where there is no
Exactly. Your vessel is an extension of the catheter. So the moment you stop injecting, it will stop going forward. It will just stop there. But that does not happen when there are intercompartmental connections. The moment you breach this compartment and go into the intercompartment, then it will start flying off. That's what was happening. So there we have to again make it slower. And
one more thing, you said once you have breached in 2 compartments, you partially occluded the vein as well. So you said we could leave it and then go for a gamma knife or a cyber knife. Then won't it bleed because you have partially like the artery?
Very tiny. The remnant was very, very tiny. Now you also have to understand where the remnant is, so the chance of the bleed is higher. Supposing the remnant is surrounded by all sides with brain tissue, then even if it bleeds, it will be a micro bleed, it will be a contained bleed, most likely. But supposing it is sitting on the edge of the ventricle, supposing it is sitting on the occipital horn of the lateral ventricle, and then if you leave a tiny remnant, it has no splinting effect from the side of the ventricle. There's just ependyma there. So there the chances are very high. So on an AVM to AVM basis also, this decision about when to stop will change depending on the location.
Sir, as you are using glue and a non-detachable microcatheter, so how much time do you normally get for the glue embolization before the catheter gets stuck?
In a dilute glue, like 20-25%, as long as the glue keeps on flowing and does not reflux, we have injected up to 2 minutes. Nothing happens. But if you have a 60% glue, then 10-15 seconds is all what you have. Because there, even what is coming out of the tip will start polymerizing and your catheter will get stuck there. So everything depends basically on the concentration of glue that you are working with. The moment glue starts coming back, you have to remove the catheter. Because it starts enclosing the tip of the catheter, then it will get stuck. Worst case scenario, if it does get stuck, don't panic. Wait for some time. Keep on doing check shoots. New catheter, very, very hydrophilic. Nothing, no thrombus will develop on top of that. You cut it in the groin and leave it. So again, for all those of you who are coming to the lab, we'll show you some of those also. It happens to all of us. But that we don't show here, we show in complication meets.
I want to ask about the injection. I think your injection was very good. What happens most of the time with me, the glue reflects and there's not much anti-gate flow. That's the common problem with most of the injections. How to avoid that?
The most important thing is to spend more and more time on catheterization. The most important thing, because the only way you can avoid reflux is by achieving a wedged position. If you are not wedged, then the only way to avoid reflux is to go very slow. Then let the flow take the glue away from the catheter. Because the idea of curing an AVM is only when you are wedged. Even with onyx, when you do the embolization, you allow the reflux, you form a plug or whatever they call it. So basically you are wedging the catheter with the plug and then you are pushing anteriorly. So the idea is just because your catheter has engaged into a good feeder and you will start embolizing, that is not what I do. I spend time in the catheterization, I put the wire in just up to the tip, rotate it, torque it, pull the catheter, push the catheter and see if it wedges. Because if the dimension is almost the same, then the chances are good that you will get a wedging. Sometimes we shape the tip of the micro, for example, gyral AVMs, we shape the tip of the flow-guided microcatheter. We shape it so that it makes a right angle bend, it goes and wedges. So most important, you have to achieve a wedged position.
And how you know in advance that this AVM has inter-compartment connections? Because
based on the anatomy?
You embolize and you get very small chunk of nidus, then you have to make another catheterization.
In fact, that is all the more reason which is telling you that there is strong competitive flow from the opposite side, which is not allowing your glue to percolate into that area. But by anatomy, by topography, we can understand which AVMs are likely to have intercompartmental connections. In telencephalic AVMs, 70% will have intercompartmental connections. In deep brain AVMs, ganglionic AVMs, choroidal AVMs, only 30% will have intercompartmental connections. I have a case of anterochoroidal AVM where we had to use at least 15 to 20 microcatheters, go into each compartment one by one, and then we were able to occlude.
Gyral also have multiple.
Gyral have intercompartmental. They are all neopallial. Gyral AVMs are neopallial AVMs. So 70% will have intercompartmental connections. They will have. But you have to be in a wedged position. Otherwise, if you push, it will reflux.
Yeah, that's the common problem. Yeah.
You always use a diagnostic catheter
As guide.
Guide.
Yes.
So you won't be able to take injections with a.
You can. Very faint. You'll get very poor quality injections.
My question then is, sir, we saw some ACA vasospasm that was there, and before or after, and you are very selective till you reach the wedge position to inject. So then there are two parts to it. Then the vasospasm is very difficult to detect because you have a diagnostic catheter inside, which means
Yes.
you cannot take the check shoot. And the second question is, if the vessel has gone in for a spasm, sir, then the dynamics that you thought of before and after in glue concentration, does it change?
When you are wedged, no. Because the moment you are wedged, it does not make any difference. Then the angio architecture of the AVM will decide your concentration. Supposing you are wedged in a fistula, high concentration. Supposing you are wedged in a plexiform, low concentration. Because you are wedged and your AVM is an extension of your catheter. So the local flow dynamics don't affect that at all.
As long as you're wedged.
As long as you're wedged.
But then the first question then, sir. So supposing we are taking more time to engage into the AVM and the vasospasm is persisting and we have no means to check it, you don't have any infarcts that you see post-procedure because...
Here, we had seen that there was a very strong ACOM and we knew that the opposite ACA is filling. So distal in the ACA territory, you would have very good cross flow. So here also, because even though the vessel was in spasm, we were able to see only the MCA territory opacifying. We were not seeing any blush in the ACA territory. So that means it was coming from the opposite side.
Then I'll rephrase this question, sir. So how quickly do you try and reach your nidus so that you feel that... Or
See, you do, for example, you have an ACA embolic occlusion. Even if you open it at around 3 hours, the patient will do well.
I know, but...
So here, see, if it is an easy catheterization, you remove the whole thing, wait for some time and then start again. But if it is a difficult catheterization where you've already spent 1.5 to 2 hours to reach there, then better to finish the job and then see what to do about the ischemia and what to do about the... usually there will not be infarcts because we do MR on these patients on the next day. At least in this case, I did not see anything.